Just to share the screen. Okay, so today we're talking about extraoral imaging, and our learning objectives, of course, as always, is to pronounce, define, and spell the key terms. We're going to discuss panoramic imaging, including the following: the purpose and uses of panoramic imaging, the equipment used in panoramic, the steps for patient preparation and positioning in panel imaging, and also the errors that may occur during patient preparation and positioning during panoramic imaging. So extraorals are outside the mouth. They're taken when large areas of the skull or jaw must be examined, or when patients are unable to open their mouths for film placement. As we mentioned before, intra is inside, extra is outside. So extraoral radiographs are useful in evaluating large areas of skulls and jaws, but are not recommended for detection of subtle changes like caries or early periodontal changes. Introduction of full-featured digital panoramic units and a new technology called cone beam computed tomography, CBCT. Almost all digital extraoral images have better resolution than film-based images. Not too many doctors have that CBCT yet. Some do, some don't. Probably more the specialists have them. Panoramic imaging allows the dentist to view the entire dentition and related structures on a single image. If you guys remember, I gave you a packet with about, I would say 4 or 5 different panel imagings, and we looked at it. And what did we see? We use it to locate impacted teeth, detect jaw lesions, observe eruption patterns. In the past, panoramic images were not recommended for diagnosing dental caries or periodontal disease or lesions because of the overlapping of posterior contact areas. Bite wing images had to be used to supplement the panoramic images, and they still are. The other thing about panel, and we'll talk a little bit more about this when I show you guys a picture, that it is operated while standing. And we can change it and lower it for people in wheelchairs. Hold on a second. Let me just. People are having trouble logging in, so I'm just letting them know, log out and log back in. Okay, structures seen on panoramic images. So I kind of showed you the main things that we wanted to see, which was impacted teeth, the jaw, TMJ, sinuses. But if you guys look in your figure 42.1 in your book, then you can go more into detail of everything from the mandibular condyle to the styloid process to the nasal cavity. I mean, there's so many other things that you guys can look and see. It's best, though, that you take your time, because that will be a lesson that you would have to go over and over. Honestly, again, the most important things that for you guys, because the rest is really for doc to know a little bit better, is sinuses, the jaw, knowing your right from your left, the impacted teeth and the missing teeth, and also restorations, which you guys were doing great when we were reviewing this yesterday in class, of what crowns are, root canals, missing teeth, fillings, amalgam versus composite. So that's already a plus for you guys, and you want to just keep that up. Now, this situation has changed with the introduction of the new featured digital panoramic units with a special C-arm. Panoramic digital images produced with these machines can show small interproximal carious lesions. They can open up contacts in the premolar areas that traditional panoramic machines showed as being overlapped. There are 2 types of panoramic machines, a film-based and a direct digital imaging. The main difference between digital and film is the image receptor. That's the only difference, okay? Digital units use a sensor array rather than film, and the image is produced immediately on the computer monitor rather than on a film after processing. So again, that's the only difference. If you use a sensor, boom, it pops up on the screen, just like this one. If you don't use a sensor, then you take out the film and you go and process it. Now, would you be able to process it in our automatic processor? No, because that one is only meant for size 2, size 1 film. You would need the big automatic processor. As we lectured before in our book, there was an AT 2000, that's the big one, and that one is the one that you can put the panoramic film in. So as I mentioned before, these panoramics, they are usually, you have to go inside of it and stand in it, and then it goes around your head. We'll go over a little bit more of that. And then in this panel, if you guys look real closely, this person has braces on, and that's what you're seeing. Also, they have their 4 wisdom teeth, okay, coming in. More than likely, they will be taken out. They're still in the bud stage, so the doctor is probably waiting a little bit until they come out a little bit more. And then here, up here, you have the sinuses, okay, on the maxillary. So again, take a real good look at that x-ray on figure 42.4. Basic concepts in panoramic imaging: both the film sensor and the tube head rotate around the patient, and it produces a series of individual images. When these images are combined on a single film, an overall view of the maxilla and the mandible is created. So this is what they're showing you. This is the panel machine where they start, okay? They stand in the machine, as I told you. And then when you guys hit the button, all you got to do is make sure that the patient is in properly with their chin up, tongue to the roof of their mouth. That's real important. And then to stay still. You hit the button just like you hit an x-ray button. Okay, that's what begins the machine. So it starts from here and then it goes around the head and it ends over here. Okay, you tell the patient not to move until it ends, and then you will reset the machine to go back to start position. All right. And then that's how the machine takes the entire right to left. Now, the focal trough. Miosha, can you see the slides?
Yes, I can see the slides.
You can or cannot?
I can.
Okay. Ayana's saying she can't. So I'm just checking to see why. I don't know why she's having difficulties. Okay, sorry about that. All right, so focal trough is an imaginary 3-dimensional curved zone in which structures appear clear on a panoramic radiograph. When a patient's jaws are positioned with this zone, the resulting radiograph is reasonably clear and well defined. If jaws are positioned outside of this zone, images on the radiograph appear blurred or indistinct. The size and the shape of the focal trough vary with the manufacturer of the panoramic unit. Panoramic X-ray units are designed to accommodate the average jaw. The quality of the resulting radiograph depends on how the patient's jaws are positioned within the trough and how closely the patient's jaws conform to the focal trough. And this is what they're talking about. So the focal trough is an image layer of a panoramic machine. Structures in the middle of the layer, the darkest area, will be sharply depicted. Those toward the periphery will be less sharply depicted. All structures outside the layer will be blurred and magnified. Most people view this as a horseshoe shaped. That's one of the best ways to recognize the lower. Now, the equipment You need the tube head, the head positioner, the exposure controls, and the film and intensifying screens. The panoramic X-ray tube head is similar to your intraoral tube head. So the tube head that you guys been actually taking X-rays with, it is very similar to that. It has a filament that produces electrons and a target that produces radiographs. Collimator used in the panoramic X-ray machine is a lead plate with an opening shaped like a narrow vertical slit. Different from the intraoral tube head, the vertical angulation of the panoramic tube head is not adjustable. Tube head of the panoramic unit rotates behind patient's head as film rotates in front of patient. So basically, again, the patient gets in, it goes around their head, the patient doesn't move. And with the head positioner, each panoramic unit includes a head positioner used to align the patient's teeth as accurately as possible. Each head positioner consists of a chin rest, a notch bite block, a forehead rest, and a lateral head supports or guides. Each panoramic unit is unique, and the operator must follow the manufacturer's instructions to position the patient correctly in the focal trough. Now, with the panoramic, we do disinfect it and we do use barriers because the patient, if you, for those of you that wear eyeglasses, to me is very similar for when they ask you to put your chin on that chin rest and bring your head forward, and they kind of adjust your face where they're checking your eyes. So panoramic is pretty much like that. It's super easy to use, even though we don't have one. You know, when you do go to an office, if they have a panoramic, I mean, in like less than 5 minutes, you'll know how to use a panel because, again, all you got to do is have the patient come in, put them in the head position and make sure that their head is nice and straight and that their tongue is up to the roof of the mouth, and then the machine goes around their head. With the exposure controls, you're going to allow the milliamperage and kilovoltage settings to be adjusted to accommodate patients of different size. The exposure time cannot be changed. So basically, what you're going to change is if it's an adult or if it's a child. Also, it has film and intensifying screens. The film-based panoramic imaging uses a type of extraoral screen film that is held in a film cassette. This type of film is sensitive to the light emitted from intensifying screens in the film holding cassette. This cassette is a little bit different than the intraoral film imaging. Now, there are common errors to produce a diagnostic panoramic image and minimize patient exposure. You must avoid mistakes. You must be able to recognize the following common patient preparation and positioning errors and understand what you can do to prevent such errors from occurring. I'm going to tell you one of the biggest mistakes that most people do is that they don't ask the patient to take off their jewelry from the neck up. That's number one mistake. The next mistake that a lot of assistants do is that they don't ask the question, do you have anything removable in your mouth? Like dentures, partials, tongue rings, lip rings. We mentioned yesterday, nose rings. You know, all these things have to be removed. And believe it or not, if someone is wearing a metal hair clip or any type of clips in the hair, those need to come off too, because they do come out on the x-rays, okay? Anything with like a metal clip. One time, we were trying to figure out for the longest what was inside the panel, and it turned out to be the little metal clip from the ponytail holder. You know, when that little clip holds the ponytail holder, it's just a little metal clip there, and we were wondering what the heck was that until we looked in the patient's hair and saw that their ponytail holder had a metal clip. So things like that too can ruin your x-rays. All right. So again, it's important, you know, to know what you need to do. So patient preparation errors, ghost images. If all metallic or radiodense objects are not removed from before exposure, a ghost image results. A ghost image looks similar to the real object, except that it appears on the opposite side of the film. The ghost image will appear blurred and larger. The solution is the patient must be instructed to remove all radiodense objects from the head and neck region before being positioned. So what do you guys think that is?
Are you asking what you think the picture is?
Yeah, what do you see on the picture? What's the ghost image?
It looks like earrings.
Right, it is earrings. Notice also above the hoop earrings on the left and right, there's even the little tiny earrings. The, what do we call those? The post earrings? Studs. Yeah, the studs, things like that. So it appeared, a ghost image appeared on the panoramic, and above the hoops, if you guys see my arrow here, above the hoops, here's the ghost image of the studs. So not only did the hoops come out, but the studs came out too. So is this a good x-ray?
It is not a good x-ray.
Exactly. It is not a good x-ray. So the other problem that we have is a lead apron artifact. So if the lead apron is incorrectly placed, or if a lead apron with a thyroid collar is used during exposure of panoramic films, a radiopaque cone-shaped artifact results, and it interferes with the diagnostic information. So the solution is use a lead apron without a thyroid collar and place the lead apron low around the neck of the patient so that it does not block the beam. So here it goes. So here's somebody that they put a lead apron and it was around the neck and it threw this shadow on it. So this is not good, okay? This is not a good x-ray. You know, believe it or not, most people don't even use a lead apron on the panel because it's so quick and the radiation is so low that nothing's going to happen. Now, to make the patient feel more comfortable, yes, we do use a lead apron, but try to remember again, one without a thyroid collar. Lips and tongues, patient positioning errors. So the patient lips must be closed on the bite block during exposure of a panoramic film. So as I told you, they step in, they put their chin on the chin rest, and then there's this little stick, and they bite on it. When they bite on it, they should wrap their tongue around it, their lip around it. Also, the tongue must be in contact with the palate. So I just finished mentioning that to you too, the roof of the mouth. If it is not, the result is a dark radiolucent shadow that obscures the apices of the maxillary teeth. Again, the solution is close the lips around the bite block, swallow, and then raise the tongue up to the palate. And here is a picture of if we ask the patient to do it correctly, then we will have a good picture. I want you guys to see this. A lot of you guys were confused before. If you see my arrow, there was some panels that I showed you before, and some of you guys said that that was a implant and it was root canals. An implant actually looks like this one right here where my arrow is. So there's the difference, okay? It looks like a screw, okay? And then, of course, we talked about these, all right? Crowns on the teeth, and we have some fillings on the teeth, okay? So again, we're recognizing off the bat, I can tell you all the wisdom teeth are missing. And then if we have an implant here, then that means that tooth is missing too. So we know 1, 16, we drop down to 17, and we know this is the left side because it has the letter L. Here's 18, so that means 19 is missing too. Coming around on the other side, 32 is missing. So right away, these are the things that you guys need to identify. The teeth that are missing, there's implants, there's crowns, and there's fillings. As far as everything else, pretty much everything else, doc is the one that diagnoses. He's the one that checks for cavities. He's the one that checks for cysts and abscesses and things like that. You may see it, but remember, we as dental assistants do not diagnose. These here are very good sinuses. You can see it really good. And over here, you can see the TMJ, real nice. Okay, nice jaw, and then the TMJ. All right, now going to more errors if the chin is too high, also referred to as a positioning of the Frankfurt plane. So if the Frankfurt plane is incorrect and the patient's chin is positioned too high or is tipped upward, the hard palate and the floor of the nasal cavity will appear superimposed over the roots of the maxillary teeth. The detail in the maxillary incisor region will be lost. Maxillary incisors will appear blurred and magnified. A reverse smile line will be apparent on the radiograph. And what's the solution? To position the patient so the Frankfurt plane is parallel to the floor. So here's what they're talking about. This is a horrible panel. Horrible. Not only do they look like they're frowning, so that's what they're mentioning. Okay, so this is their chin is tipped up too high. So that makes them look like they're frowning. And then all the front anterior look very blurred. We can't even see it. Okay, so big difference from this one. You see how this one is smiling to this one where it's frowning. It's horrible. Everything on this x-ray is horrible. So please, you see that happening, you need to reposition the patient and take the x-ray again. Now, if the chin is too low, then that means, again, the Frankfurt plane is incorrect and the patient's chin is positioned too low or is tipped downward. The mandibular incisors will appear blurred. Detail in the anterior apical regions will be lost. The condyles will not be visible. An exaggerated smile line will be apparent on the radiograph. And again, the solution is to position the patient so the Frankfurt plane is parallel to the floor. So now, like, this person looks like the Joker to me, okay? Their smile is so wicked here, like, it's like, what's wrong with this picture, you know? So this is too much. His chin is tipped down too much, okay? So we have to fix it. So that way the smile line is basically exaggerated. So again, that is not a good x-ray. If the posterior to focal trough, this is another error. So if the patient's anterior teeth are positioned too far back on the bite block or posterior to the focal trough, the anterior teeth appear fat and out of focus. So again, the solution is to position the patient so that the anterior teeth are placed in an end-to-end position in the groove on the bite block. So this is what I'm talking about. All panels are like this. You have a chin rest, so they lean their chin on here. And this is a bite block. By the way, these bite blocks have a little notch. And if you ask the patient to slide their teeth into their teeth fall in the notch, then you know you're in perfect positioning. Now, here's another thing that I use like a tip to let you guys know whether you know if the chin is too high or too low. There is, and we probably will be coming to it, there is a button, and if not, when you come into lab, I will show you what I mean. But there's a button that you press, and it will make an X on the patient's face. And that kind of tells you if you're aligned. The other thing that I tell my patients to do is when they go into the panoramic to stand straight, not slumped or slouched. You know, if they stand straight, that gives you a better picture. Also, you don't want this panel to be leaning on their shoulders. So what I do is where my arrow is right now, I stick my fingers there. And if I have room for my fingers, then I know that there's room for the panoramic to go around the patient's head. So all those are tips. Oh, and here's what it looks like if you guys don't have the patient slide their teeth into the little notch. As we mentioned, the anterior teeth look whitened and blurred, and that's a horrible panoramic film. Okay. So if the anterior to focal trough, if the anterior teeth are not positioned in the groove and are too far forward or anterior to the focal trough, the teeth appear skinny and out of focus. So again, position the patient so that the anterior teeth are placed in an end-to-end position in the groove on the bite block. So before I showed you too far, now I'm showing you too close. So narrow and blurred. Look at this. This is horrible. So everything looks like it's together. Okay. So again, the trick to avoid both of the ones that I showed is to make sure. So from this one and this one is all about making sure that the patient slides their teeth in that little notch. Now, she is smiling. When I'm ready to take the x-ray, I will tell her to put her lips around that bite stick and her tongue up to the roof of the mouth. Now, here's some more positioning errors. If the spine is not straight, so again, if the patient is not standing or sitting with a straight spine, the cervical spine appears as a radiopacity in the center of the film and obscures diagnostic information. So, what's the solution? The patient must be instructed to stand or sit as tall as possible with a straight back, because if not, this is going to happen. The spine, the cervical spine superimposes on the panel, and that's what these arrows are showing you. So again, what is it doing? Blocking out the anterior. So this is showing a horrible x-ray also. But I do want to point out that over here, this is a root canal on the right side, okay? Notice here, there's some missing teeth. So when we chart, of course, we wouldn't be using this x-ray, but when we do chart, we do need to, see on the panel what's missing, and we chart it, okay? Any questions? All right, I'm going to take that as a no. So learning objectives, we're going to continue. We're going to discuss three-dimensional imaging, including the following. We're going to explain the difference between a CT scan and cone beam computed tomography or tomography, CBCT. Describe the use of a three-dimensional imaging. Discuss the advantages and disadvantages of CBCT. And we're going to identify the specific purpose of each type of the extraoral film projections. So a CBCT, during a cone beam CT examination, the arm rotates around the patient's head in a complete 360-degree rotation. While doing this, it takes anywhere from 200 to 600 two-dimensional images that the software collects. It then digitally combines them to form a 3D image that can provide the dentist or oral surgeon with valuable information. So again, it's really only taken, and a lot of times I'm going to tell you this, sometimes we even send the patient to the oral surgeon because usually they're the ones that have this machine. So if we really need to see something on the CBCT, then we give them a referral. We just don't tell them, hey, go to the oral surgeon and walk right in. Everything has to be by referral basis. Now, the advantages of the CBCT, it provides a 3D view of the mouth, face, and jaw from any directions. The manufacturers can provide software programs that will make it possible to clearly see all anatomical structures, including soft tissue. Some programs will even overlay the patient's facial image onto the radiographic image. The digital images can be easily adjusted, manipulated, and colorized on the computer. And because the images are digitized, they can be easily sent over the internet, allowing for collaboration and consultation on cases. So again, if we send the patient to the oral surgeon, we can just ask the oral surgeon to send it to us via email. We can send it to the insurance. We can send it to other dentists. We can get it from the hospital if the hospital takes it there. Okay, so additional advantages, even digital two-dimensional images cannot provide any information about width or depth, nor can they distinguish between the types of hard and soft tissue. But a CBCT has greatly enhanced the diagnostic abilities of the dentist by providing vital information necessary for the proper placement of implants, the extraction of impacted teeth, the examination of the mandibular nerve prior to surgery. I know many doctors use it a lot for implants. All right, and very difficult cases. So if it's somebody with a very difficult mouth, they will send them to get a CBCT and do a more thorough treatment plan for them. Again, common uses of CBCT, more dentists and especially dental specialists are investing in CBCT units for their office. You will have some time for training. It is necessary to learn the CBCT hardware. So, of course, if you go into an office that has one, they will train you on it. And additional training is required to interpret the data because they are presented in a 3D view or as a tomographic slice. Specialized extraoral imaging. Extraoral images may be obtained using film-based or digital systems. Extraoral radiographs must provide images of larger areas such as the skull and jaws. Extraoral radiographs may be taken with the use of a standard intraoral X-ray machine. Special head positioning and beam alignment devices can be added to the standard X-ray unit to aid patient positioning. Panoramic X-ray units may also be fitted with a special device known as a cephalostat. We call it Ceph for short, okay? It includes a film holder and head positioner that allow the operator to easily position the patient. Usually a Ceph is used a lot by an orthodontist, okay? Ortho is braces, and we had that in our last class, braces. Now, these also have film and intensifying screens. Most extraoral exposures use screen film placed in a cassette that has an intensifying screen. And occlusal film, we spoke about this one, size 4. Yesterday, I even showed you an image of a guy holding it in his mouth. May be used for some extraoral radiographs such as lateral jaw or transcranial projection. And occlusal film is a non-screen film that does not require cassette. However, it requires more radiation than is needed with screen film. The grid. A grid is a device that's used to decrease the amount of scatter radiation that reaches an extraoral film during exposure. Scatter radiation causes film fog and reduces film contrast. A grid is composed of a series of thin lead strips embedded in plastic that permits passage of the X-ray film. The X-ray beam, and the grid is placed between the patient's head and the film. And if you remember, we talked about scatter radiation, I believe in chapter 39, and scatters the X-rays that bounces off the bones and teeth. And we even talked about a grid, and a grid decreases film fog. So when certain X-rays interact with the patient's tissues, scatter radiation is produced, which is directed at the grid and film at an angle. Again, as a result, scatter radiation is absorbed by the lead strips and does not reach the surface of the film to cause film fog. Increased exposure time must be used to compensate for the lead strips found in the grid. And here's a on figure 42.27. Again, a grid decreases the amount of scatter radiation that reaches the extraoral film. So you'll have the patient, the grid, the film, all to protect the patient. Procedures, step-by-step procedures for the exposure of an extraoral film involve the same equipment preparation, patient preparation, and patient positioning as for panoramic radiographs. Before an extraoral film is exposed, infection control procedures must be completed. If an extraoral X-ray unit with a cephalostat is used, the ear rods must be wiped with a disinfectant between patients. So that's another thing that some panels and definitely a lot of Cephs have, and they look like ear like plugs type of things. So that's to keep the patient's head from moving. If we use that, of course, after every patient, we must disinfect it. Do you want to do a couple of slides? I'm going to have a guest help me out here for the last few slides, and this is Miss Chin.
Okay, skull radiography. Used most often in oral surgery and orthodontics, although some skull films can be exposed with a standard intraoral radiographic machine, most require the use of an extraoral unit and cephalostat. Skull radiographs may be difficult to interpret because the numerous anatomic structures that exist in the area. Often these structures appear superimposed over one another. The most common skull radiograph used in dentistry include a lateral cephalometric projection, a haven't heard that word in a while. Posterior anterior projection, and the TMJ projection. The lateral cephalometric projection is used to evaluate facial growth and development, trauma, disease, and developmental abnormalities. This projection shows the bones of the face and skull as well as the soft tissue profile. And then we have a little image here. What image is this? 42.28. For the lateral cephalometric projection, proper patient and film positioning are shown as viewed from the front, side, and the top of the patient. Okay. You want to help me with that?
Posterior anterior projection
is used to evaluate facial growth and development, trauma, disease, and developmental abnormalities. This projection shows the frontal and ethmoid sinuses, the orbits, and the nasal cavities. And then we also have an image here, which is figure 4229. For the
posterior anterior skull projection,
proper patient and film positioning are shown as viewed from the side, back, and top of the patient.
So class, I wanted to tell you guys to, just like you help each other, instructors help each other too, okay? So we are all together as a team, all right?
Alrighty. And for the TMJ radiography, these radiographs of the TMJ can be very difficult to examine because of the multiple adjacent bony structures. The articular disc and the other soft tissues of the TMJ cannot be examined radiographically. Special imaging techniques, such as an arthrography and magnetic resonance imaging, must be used. Radiographic projections of the TMJ can be used to show the bone and the relationship of the jaw joints. Do you guys have any questions?
Class, anybody has any questions?
No.
All right, let me take attendance. Give me a second, please. All right, let me stop the recording.